Good afternoon. My name is Josie, and today I'm presenting my quality improvement project focused on fall prevention in home health. This project was developed for West Calcasieu Cameron Hospital's Home Health Agency, which is where I work, in response to a pressing patient safety issue, the high rate of patient falls occurring in the patient homes. Over the next 10-ish minutes, I'll take you through the background of the problem statement, aims, plan interventions, and how we will measure the success of this quality improvement project. Okay, background and significance. Falls are the leading cause of injury among older adults in the home health population. According to Paul and Associates, over 75% of patient falls happen inside of the patient home. At WCCH, West Calcasieu Cameron Hospital, we are averaging 10 to 12-ish patient falls per month, depending on the census and depending on the time of year. These falls not only lead to injury and hospitalizations, but they also increase healthcare costs, reduce the quality of life for the patients, and create time-consuming setbacks for the nursing staff and the agency as a whole. This high rate of falls demands immediate attention. We need an actionable solution tailored to the home environment. This home environment is specific because it'll be a little bit different than your clinical environment, like in the hospital, nursing homes. It's a different set of standards. Problem statement. At West Calcasieu Cameron Hospital Home Health Agency, an average of 10 to 12 patient falls occur each month, often resulting in preventable harm and increased strain on staff. As patients gain independence in managing their care at home, it is critical to implement proactive, tailored fall prevention plans. So currently our fall prevention protocols are pretty generic when it comes to home health, and they fail to adapt to your patient's specific risks and home circumstances. Many patients have pretty unique challenges depending on their specific physical impairments, cognitive issues, or even just unsafe home layouts. These things are not usually addressed in your standard protocols that you'll find in an inpatient setting. As a result, we continue to see preventable falls that lead to serious complications like fractures, head injuries, and ultimately loss of independence and hospital readmission. Okay, aim statement. Our primary aim is to reduce the number of falls among our home health patients by at least 50% over the next 6 to 8 months. We plan to do this by implementing a patient-specific, proactive fall prevention plan that uses evidence-based tools to evaluate risk and create tailored interventions. This plan is structured around ensuring that no identified risk is left unaddressed. Okay, so here's kind of our intervention overview. This specific quality improvement project will include 3 different components of interventions. First, every home health patient will undergo a comprehensive Mach 10 fall risk assessment and a home safety evaluation. These tools can help to pinpoint specific areas of concern. The next thing, which is probably the most important, is for every risk that's identified on these forms as a fall risk, there needs to be a corresponding personalized intervention documented and immediately implemented in the patient's care plan. So an example would be if a patient has poor lighting in the home, implementation is going to be number 1, education, and helping a patient find night lights or moving a lamp to that area that's not well lit. Something even as simple as that, but that's patient specific and specific to that home. Or, maybe if they're on sedating medications, sending a note to the doctor and getting some specific dosing and specific instructions from the doctor on how to take this medication, and let them know that maybe they're having some complications and increased sedation. The third component is going to be an EMR embedded checklist. So this is going to make mandatory fields in these assessment pieces. So for example, like I said, if someone clicks that fall risk for poor lighting or sedating medications, a mandatory cell will open that will require the nurse to document the intervention that was applied to that risk factor. Along with that, in the EMR, there's going to be a checklist for your chart auditors to make sure that for each of these risks, there's a tailored intervention. This makes sure that nursing staff is accountable and they have to complete those interventions before moving on their documentation. And the process will work as an evaluation system in itself as well. Okay, timeline. This intervention is designed for rapid deployment. We already use the Mach 10 form and home safety evaluation. That's something we're already implementing and doing on our assessments. The only minor adjustments are going to be the interventions that go along with it. We can implement this change immediately following a brief training session with the staff. The form completion will be the same, and the staff is already familiar with the form. The only difference is going to be with each indicated risk. The nurse will be again responsible for implementing and documenting intervention to address that risk. We'll begin data tracking at the start of implementation and evaluate progress monthly, just like we do with our falls anyways. By the 6 to 8 month mark, we aim to achieve a 50% reduction in falls. Process measures. We'll monitor 4 key process measures. First, the percentage of patients with a completed Mach 10 and fall risk assessment. Second, and most importantly, the completion rate of the home safety evaluations. And third, the most important, the percentage of the identified risks that are matched with the documented intervention. And finally, the percentage of complete fall incident reports that are submitted within 48 hours of a fall. These measures will help ensure the interventions are being implemented, the process is being followed, and also track the efficiency of the measures. The outcome measure kind of goes along with this. The primary outcome measure we're going to be tracking is the number of falls that we're experiencing. Like we said, we hope to reduce this from the average of 10 to 12 falls per month to more like 5 to 6 falls per month. This data will be compared over time to assess the effectiveness of the intervention and guide adjustments as needed. Data collection plan. Data will be gathered through monthly chart audits and conducted by nurse supervisors and quality improvement staff. They will verify completion of assessments, matching interventions, and timeliness of incident reports. All data will be entered into a shared Excel tracker. The auditing staff already uses this Excel tracker, and they already have several cells where they're making their checklist of the things they require for admissions packets. So this will just be an added cell, an added component to something that we're already using in the agency. This tracker will allow us to create visual aids such as run charts to monitor trends and performance. Okay, speaking of run charts will serve as a simple yet powerful tool to help us track progress over time. So we're hoping to show that we're going to have a decreasing trend in falls while showing an increasing trend in the completed fall risk assessments and, of course, the completed matched interventions to the fall risks that are indicated. These charts will help us identify when the intervention is working and if we maybe need to tailor it and add some additional support. Barriers and solutions. Potential barriers include staff resistance to new documentation requirements and the risk of focusing too narrowly on fall prevention while maybe neglecting our broader patient needs. So to address this, we need to provide brief, focused training that emphasizes how the intervention integrates into holistic patient care. And also by the fact that it's already something that we're doing, we're just going to be a little bit more thorough, a little bit more specific, and proactive in the completion of these forms. We're not just completing them to complete them, we're completing them to help build our care plan. We'll also simplify the documentation by embedding the mandatory fields. So as I said, if we click a fall risk, it's going to pop up a bubble right there that says, okay, here's the risk. Okay, what did you do about it? This will make it so we're not doing extra paperwork. It's not an additional form. It's not going to take extra time. It's not going to take additional funding. It's a form we're already completing with some adjustments. Team leads will reinforce the importance of balancing fall prevention with overall care goals. So, again, this is going to be really important on admission, the fall prevention care plan and all of that, but we need to make sure that this doesn't overshadow, our primary admitting diagnosis for the patient. Sustainability plan. Sustainability will rely on incorporating this initiative into our standard operating procedures. Fall risk assessment and intervention documentation will become part of our routine care and chart audits. New staff will be trained on the protocol during onboarding, and compliance will be monitored through ongoing audits, like I said, that are already being done. Leadership and quality improvement staff will be responsible for upholding long-term adherence. So again, we're already doing these forms. We're already completing these mock 10 and the home safety evaluation. So the sustainability chances are really high. We've got a good chance of this working because our nurses are already completing these forms. We're just asking for them to be a little bit more proactive in using those forms to what they're intended to be used for, to identify our risks and try to combat those before they become an issue for our patients. Evaluation strategy. The effectiveness of the intervention will be evaluated by comparing fall rates and process measure compliance before and after implementation. So we expect to see reduced falls, increased completion of those forms and assessments, and improved reporting. If these improvements are sustained over time, the intervention can be considered successful and continue to be implemented. If not, data will be used to identify gaps and kind of refine what we're working on and if we need to change this implementation. Okay, so key references. This plan is grounded in strong research. There was a few main resources that I found that kind of helped support this intervention. Gurgis and Blake and Associates demonstrated that multifactorial and tailored interventions are in home health are more effective than like standardized approaches. So again, better than using our cookie cutter fall prevention forms or interventions that work well in the hospital, don't really fit our specific patient homes. Stark and Associates also proved that the effectiveness of targeted home hazard removal in reducing fall risks was also really strong. So fixing your home environment is not necessarily a medical intervention, but it is something in home health that we're going to start focusing on and is a huge factor when we're talking about fall risk in the home. And finally, Smith and Associates highlighted the risks of living alone and environmental hazards. So again, this is specifics for our patients' environments. A lot of our elderly patients in home health are by themselves, and that's something for us to consider too. Patients like that, if they're living by themselves, that's a risk factor for falling and a safety risk. So that patient might be more qualified for like a lifeline or something. So again, this is something that if that's a risk that's identified, that's going to be a mandatory implementation of some intervention. Okay, and that brings us to the end. Thank you so much for your time and attention. I look forward to any questions and feedback, and I hope we can together create some safe home environments and improve outcomes for the patients and the community that we serve. Thanks.